Now the floor is open for question and answer. I welcome questions from all of us, for the Zoomers and for those who are in this room as well. Maybe to get us started, so I will start with the first question to Rachel. So you have clearly shown us how the introduction of elastomeric infusers has transformed the use of antimicrobials in the outpatient setting. So obviously these are not without limitations. So one of the challenges that we note is the erratic flow rate with some of the elastomeric infusers. So do you see this problem often in the clinical settings, especially with some antibiotics where the viscosity of the formulations is high? So there are some reports which show that the flow rate may be erratic. So in such cases, how do you manage them clinically?
So we do see a few times where our 24-hour infusers, so such as like the meropenem, tazocin, it doesn't completely run over 24 hours. Like you're saying, it's just the flow rate's not all there. So what we tend to do is we sometimes let the patients run it for a bit longer, and then just change their second lot of infusers, which is usually the tobramycin if they're on that as well, a little bit later as well. It's very hard because it is quite difficult for us to manage, but when they do come in, we do sometimes tell them to take the infusers out of the fridge a little bit earlier, just to warm it up so the body heat can actually also help with the flow. But most of the time we just sort of bring them into clinic. Sometimes it could just be a simple troubleshooting, like it's not well connected. The infuser itself is probably not well. So when we're doing all this education with our patients, we tend to show them that if your infusers aren't working, what are the steps, what are the troubleshooting side of things, and then contact us if there is any other issues.
Great, thanks. So we have some questions online. So the first question is, how is meropenem given in HTP? So I'm not sure for who this one is directed, but any one of you. Go for it, Rachel, if you want.
I can start. So with us, the way we give our meropenem, so it is a little bit different because we are semi-underdosing when they do get discharged. So in hospital, we are giving 2 grams of meropenem 3 times a day. Whereas because of the compatibility of the Baxter bottles, you can't do 6 grams completely into those infuser bottles. And that's why we use the 4.8, which is it is lesser antibiotics in there. We do have with pharmacy, and our company that we use is Baxter, which Westmead uses, like an agreement that helps us get that 4.8 in the infusers to get done that way. And then it just means that the patient will just have regular pickups because of the life shelf that it has. Hopefully that answers a bit of that question.
So I hope that answers the question. So if in the room, if anyone has a question, please raise your hand. So, but we have some more questions online, so we can continue. Okay, we'll perhaps mix one from the room and one from Zoom.
Thank you for all the speakers and their valuable contribution, firstly. A question for Dr. Ong. Oh, sorry, I'm Sam from Hospital and the Home at the Royal Brisbane. Dr. Ong, I'm just curious if you had any experience with treating women with hyperemesis. They, by default, are generally more, predisposed to thrombosis. Our obstetrics team here like to anticoagulate all of their consumers. Do you have any experience or comment in that space, please?
Not quite. I think most of our hyperemesis patients, we do. I suppose this is the way our service is set up. We treat them in the unit, and we would give them intravenous boosts. The community nurses have not sort of started giving them in the home. I would think that yes, maybe if you're actually using a central line, you would. I would think it's not unreasonable to give them some prophylactic anticoagulation anyway. But that's we don't treat patients with central lines in the home anyway. So most of them are treated in the unit.
Thank you.
So, Marta?
Hi, I'm an ID physician. I wanted to ask you because, sorry, it's for Dr. Ang as well. One of the worst experiences I've ever had was that we had a patient that was sent home to OPAT and came back with a MRSA sepsis with endocarditis. And the patient was tested at the entrance of the hospital like always, and he was not colonized by nasal colonization by MRSA, but it was a hospital acquired. So since then, I test everyone before leaving, and if they are positive, we do the decolonization. But this is a thing that it's not protocolized, but we do it in some hospital settings. I wonder if you take some kind of precaution regarding this for patients who go home with a central line.
I mean, obviously, if they come from ICU and they were in hospital, they would get the standard, in hospital, they would get the standard MRSA swabs. I think for us, we would just still follow the same protocols. I think my thoughts are, I suppose they could get an infection from a standard Staph aureus or MRSA. So we don't particularly look for that. But obviously, if they come from high-risk settings, like in hospital or ICU, yes, I mean, that would have been done already.
Yeah, because what we do is now is the nasal decolonization and chlorhexidine washings and everything. But I was wondering if there was a protocol or something like this in Australia. Thanks.
Thank you. So perhaps we should go for the next question for online. So maybe this is for you, Karen. But you've kind of addressed this, but it says which line is used commonly, perhaps in antibiotic administration in OPAT?
If you're talking about line as in central line or PIC line, generally here in our health service, it's a PIC line is the predominantly used one. And as Sam, our health nurse sitting here, who's been a great source of advice, so short term would be a longer cannula or PIVC or a midline.
So the next question again from online. So it says, is there any machine available in OPAT to deliver antibiotics in ambulatory patients? So I presume this relates to electronic pumps, maybe?
I suppose I could start. Everyone could comment. Yes, they are. We actually use the Baxter infusers because we find it easier to use. But there are some services that do use infusers. Yeah.
And we have we do use some CAD pumps, but generally not so much anymore. But they still are in use.
We also mostly use Baxter with our infusions here.
The next question is for Dr. Ong. What's your approach to PIC migration? Do you routinely place PIC that have migrated, particularly inwards?
Yeah, I know PICs can migrate inwards, upwards, and actually backwards as well. I suppose the first thing is to know how much they have migrated and know exactly what it was initially, and often we not uncommonly we would do an X-ray, and also we reflect on what antibiotics we are using, and obviously if it's one of the vesicant drugs of vancomycin and it's actually moved into subclavian, we will need to do a risk assessment on whether we need to replace it or depends on how long we're going to use it for and whether it's suitable. So in terms of migration, it depends on how much there is, and obviously with concerns, a chest X-ray is usually what we would do first.
Yeah, thank you. So perhaps Karen, you may comment on the next one as well. So I think we kind of addressed it somehow, but if any of you would like to comment on it again, so the question relates again to the use of electronic infusion pumps.
I think the infusers that Rachel was talking about, are very reliable these days, and you've got options for different variations for one concentrations, but also for time. And so I think that's why there's just more of a focus and are more likely to be used these days than electronic infusion devices. Stability of the drug, well, that, again, Rachel probably might be able to answer that better. Some of those things she presented there at the start, where you're talking about what the temperature, the length of the time that it's been mixed and how long it can last. Maybe Rachel might want to add to that.
Yeah, so we, like you were saying, depending on the temperature, how long it'll last, we tend to use the infusion bottles preferred, apart from the electrical infusion pumps, just for it's easier for our patients. They're not attached to anything. It's just a small bottle. They can have it underneath their shirts, underneath their bum bags. It's out of the way. But yeah, like this is stability I was talking about. That's why our meropenem we had to drop, because it's not stable enough to have that much meropenem in there. So we are unfortunately undertreating a little bit there, but most of the other medications and antibiotics that we do use are quite stable in those bottles. And then most of them can be put through in a different rate and concentration. We just tend to do it over 24 hours with another bottle of tobramycin in between.
Thanks, Rachel. I think the question from Sarah, I think, relates to you, Dr. Ong. So would you like to comment on it?
The next question is on, you're talking about SPED and
Yes.
flushes. We don't do SPED, and I mean, I have to say that the incidence of embolism with PICCs are very rare, and I suppose is actually more common with SICs than PICCs, and PICCs are quite rare though. We don't. You talking about for SPED? No, we don't. For us, we don't do SPED anyway. And I presume you're referring to Rachel or the question.
Yeah. Yeah, thank you again. So I think the next one is just a comment. Or Rachel, do you want to add anything on this?
No, like we do the same, like depending on our patients with prophylactics, we don't give much, but we mostly do use Portacats, midlines. We don't tend to use, I think going on to the next question, we don't use PIVCs for our outpatients at all.
Okay, thank you. I think the next question from Anastasia, perhaps I think it is related to you, Karen. Would you like to comment on it? Regarding a protocol on PIVC dwelling time?
That's CF lung transplant patients as well. So,
Yeah, so if any of you would like to comment on it, so you're welcome. So,
I don't believe we routinely do VTE prophylaxis for our PICC patients. I don't know if anyone else does.
Yeah.
Yeah. I think the recent studies that suggest there's some benefit for sort of VTE prophylaxis, though, but it has been sort of equivocal for some time. A lot of major studies are done in cancer patients, but I would think that if you do have increased risk factors, and whether you want to use the Michigan risk score, it would be really quite appropriate to give VTE prophylaxis, but I probably think not routinely to all patients at this stage.
are there any more questions from the audience in the room? So if not, so maybe I'll ask the next question. So the next question, maybe to Karen for you. So you've mentioned antimicrobial coating for line devices may be useful in terms of preventing infections. So is there any risk in terms of emergence of antibiotic resistance because we'll be exposing, a whole lot range of organisms to the coating?
I guess that's always the risk and the flip side of it, and the concerns. The evidence suggests that the benefit for those patients with risks of CLABSI, that it is worthwhile and it is a good prevention. I guess that's question about the antimicrobial resistance, you actually probably may be better placed to answer that than myself or maybe somebody else, or Ben might be able to answer that one. But yeah, I think it's still a
You know,
still
I would
a
agree with
question
your
and risk out there. But yeah.
So great, maybe one more question for Dr. Ong. So maybe in terms of, minimizing the adverse events from lines, I think one of the, maybe the recommended intervention will be general in terms of antimicrobial stewardship to transition to oral agents in terms of COPAT practice. So, but there is an ongoing challenge in terms of some special patient populations, such as those with diabetics, for example, with malabsorption issue. So how do you manage the transition from IV treatment to oral regimen in OPAT programs for such challenging populations with malabsorption issues?
Yeah, I think there would probably be a case-by-case basis. I mean, particularly with the restricted antimicrobials and also the long-term antibiotics. We work with infectious disease physicians. We do also follow patients up following the completion of the IV antibiotics. And in the cases where there are concerns that they might not respond to orals, or again, if we got concerns about absorption, we don't really like to do this, but sometimes we leave the PICC line in, because if they don't respond and they deteriorate, we may have to recommence the IV therapy.
Great, thank you. So, do you want to comment or? I think so. We've addressed the next question, so we don't have any outstanding questions at the moment. So if there are any questions from the room, you're welcome. Those in the online as well. So please feel free to put your questions in the Q&A chat box.
Just make one other.
Can I just make one other comment around that, the PIVC dwell time for HIF patients in the community? I'm not sure, Anastasia, if you're saying that we should be changing them in the inpatient environment every 72 hours, but the national clinical standards that we only change them if it's clinically indicated, not 72 hours. You may have been referring to, should we in the HIF environment change them every 72 hours? I'm just not clear on that, the way that's for that question, but we don't change them routinely. It's clinically indicated. I don't know if you do anything differently, Ben, the fact that you use the PIVCs.
Yeah, it's the same. We do prefer to change it every 72 hours, but sometimes we extend the use. Particularly, there be some cases where the venous access is very bad. And also occasionally some patients actually prefer to leave the line on because they know it's a difficult access. But we usually, particularly in the out of hospital setting where the supervision is not as tight as in the hospital environment, we do tend to change that at 72 hours.
And Anastasia, in South Australia, you're saying that in the HIF environment it's 72 hours? Specifically? HIF? Anyway, thank you.
In the meantime, so I'll ask the next question. So maybe to Rachel. So are there any prospects for smart devices being introduced into the outpatient programs? So there are some smart devices that, for example, can be used for wireless monitoring of flow rates, for example. So is there any prospect on this?
Currently, we haven't ventured and looked into it yet. There was a few devices that we were thinking of changing our infusers to see which one would work a bit more better. So far, we've only come up with Baxter, which infusers are quite good for us. So currently, we haven't looked into it. So it's probably a bit more research that we probably will have to do while we're expanding.
Thank you. So I guess we are approaching to the end. So if there are no more questions from the room or online from the Zoomers, we shall, before we end, do we have any housekeeping? So, survey, yeah, great, thank you. So, just quickly grab your phones and scan the QR code, please, and give us feedback so that we can improve this program for next year. So we'll be having at least 1 or 2 HIS master classes for next year as well. So if you advise us on how we can improve this program, we would be very grateful. So we'll wait for maybe a couple of minutes until you get to scan the QR code before we close this session. You can also see the 2025 education program online by scanning this QR code, and please subscribe to our education program. So you will be able also to access all of the previous education program seminars on our YouTube channel. Subscribe, please. And follow us on Twitter and LinkedIn as well. And thank you everyone for your time. So look forward to see you next year.